Hey everybody, I'm going to get everything ready and then we'll get started. So let a few more people get in. All right. Looks like we only have 5 people on right now, which hopefully some more people pile in as we go. I just need to confirm that you guys can hear me. Anyone?
I can hear you.
All right, perfect. And you guys can all see the program development resources screen, correct? Yes and yes. All right, thanks, Sadie. So I know last week we ended with just some ask of you guys to kind of look around your community and see if there was any additional resources that you guys could identify for your potential program. And so I'm going to leave it open to you guys to kind of start that discussion. Let me know if there was anything else that you were able to find.
Yeah, Travis, this is Bob Helena. And I was looking at the YMCA, the YWCA. They've got several programs out there for battered and abused elders and also senior citizens out there on the truck route as far as the meals and transportation, loan of equipment like walkers, canes, wheelchairs, bath seats, commodes and things like that.
Awesome. Yeah, that sounds like it would be a great resource. I know that in our CHEMS program, there's a lot of times that people just need the right direction to pick up some stuff. We'd go into some of the homes where the walkers are just not in the best condition. They could probably use a better one, right? And so those are some items that can be pretty spendy if they buy them on their own. So yeah, those would be good resources to be able to send over to people. I'm glad you found that, Bob. Anybody else find any additional resources within their area? All right. Well, take silence as no. As you guys continue to work on your programs, you're going to find more and more stuff. And as you outreach to more and more people, they're going to give you some ideas of some additional resources that you might be able to get at. So as you start going out to your stakeholders and saying, this is what we're going to do, and this is kind of the issues that we have, they will come around and will kind of give you some ideas of some areas to look into, or they may have connections that you didn't know that were out there. I know with behavioral health, just attending some of the meetings that we attended, there were some great opportunities for us to develop some partnerships with groups of people that I didn't even know existed. And there's going to be a lot of committees and groups of people that get together that you probably didn't even know were out there. I know every month Intermountain goes out to all the rural areas around our area, and has meetings with everybody and tries to figure out, where can we meet some of the issues or needs within their communities. And they all get all these different people within the mental health community together, and they all talk about the resources they have available and what they can do to help people out. And so as you guys start reaching out to your stakeholders, you're going to find more and more. The second ask I had for you guys is just, if you went on calls this week, if you identified anything that, as a chems provider that you might be able to fix while you were on that call. Didn't necessarily mean you guys did it, just that you identified it. And so I'll leave it open to people to tell me if any of their calls this week, they found anything that they were able to identify now that we've started to talk about that stuff.
Can you hear me?
Can hear you, Kim.
Okay, so like we went on a call last night, and this was the second night in a row for a guy who has fallen, and he's pretty weak, and he was coming back from the bathroom and he fell. And so I made the suggestion that he keep a urinal by his bedside, and also maybe get I told him that I would provide a gait belt for them so the wife could help him. If for some reason he felt like he actually had to walk to the bathroom, the wife could put a gait belt around him. And then perhaps if he was going to start to fall, she could kind of counterbalance him to where he wouldn't fall. He also has a walker, and I'm not sure if he was actually using the walker or not, but he does has frequent falls, and we've been visiting quite often. So I'm hoping that with the assistance of a urinal and a gait belt, maybe that will keep him from calling us.
Yeah, awesome, Kim. And I guess my next ask to you, maybe the next time you're there, is to see what kind of medications he's on. Is he on Lasix, and is he taking that Lasix at night, or does he take it during the day? Sometimes you can reconnect with the physicians and be like, hey, we keep going on this guy for falls because he's told to take his Lasix at 8 o'clock at night. And now he's getting up all the time during the night to go pee, So I think your fix is awesome. That urinal was what, $1 fix right there, and the gait belt a little bit more. But, if you provided that, that's super awesome. And just sitting and talking to them and saying, hey, I know that we come out here and help you every time you fall, but one of these times you're going to fall and break a hip, and then you're probably not going to come back home. I don't think people really realize that when you break a hip, you're out for 6 months or out forever. It just depends on how severe it is. So awesome. And you probably, if he follows through with what you said, you probably prolonged his life even longer. Awesome. Anybody else?
I had one that call reminded me of, even though I haven't been going on any calls, but this was a while ago. There was one gentleman that ended up upside down in a bathtub. And this isn't a normal bathtub. It's like an 80s bathtub where it's like super tall. And we suggested heavily that he used a regular shower from then on out. But it's a matter of, you know, talking him into it, because that's what he's always used. So I guess hopefully we'll learn, you know, how to persuade them more to use something that would be more easily accessible for them rather than what they've always had.
Yeah, exactly. And Sadie, you're right. It's a little bit difficult as we get older to get in and out of a bathtub. That's why they make the little bathtubs now that have doors on them. But just suggesting a shower is good. And then even taking that a little farther as you go into the community paramedic or the community EMS program and talking about, you know, grab bars, making sure you have a non-slip surface on the ground of the shower, even a seat, like Bob said, you know, they had some shower seats at the Y that they could get. So those could be some great opportunities for these people, and just explaining to them, you know, this is kind of why we have to do this, and you know, we definitely don't want you to get hurt. So awesome. Anything else before we move forward? All right. So first part of this module is going to be module 3. It's going to be program development. After we're done with this one, we'll probably take about a 20 to 30-minute break. The reason we're taking a little bit longer one is because I am supposed to be home right now and I am not home. So I'm going to try to finish up this module, run home, and then start up on the next module. So sorry guys, we have been absolutely busy. As you can tell, a little later than normal logging in too. I think I ran probably 7 calls on top of being a director today. So it's been crazy down here. So moving forward with program development, obviously, you know, we're going to have to develop our program before we initiate it. And we talked before that a lot of this stuff is kind of the drier stuff, but it does need to happen. So the first thing we're going to kind of go to is just coming up with a plan, right? We're going to have an idea of how we're going to initiate this program, how we're going to move forward. And so what we'd highly recommend first is getting your clinicians involved. Probably the biggest failure I had at Payette was not getting full clinician involvement. There's just, in the area I had, there's a lot more people we have to deal with. You know, the primary care doctors aren't really used to dealing with the paramedics. And I think where you guys kind of take some advantages, and I know a lot of the smaller areas, you know, your ER physicians and your clinicians, your primary care doctors are sometimes the same people. And so you guys can build a better relationship. In the bigger towns or in the bigger areas, you don't necessarily have that relationship. And so here you are coming up to somebody and saying, hey, we want to do this awesome program and we want your buy-in. And hopefully, you know, it helps your patients, but we really don't have any proof behind it. You know, they tend to be a little hesitant. Plus, a lot of primary care physicians, as we all know, are busy as heck. You know, we don't have enough primary care physicians in the state of Idaho. And so they're already running, you know, back to back to back calls in the office. And then they have the pharmacy reps that are there that are trying to sell them stuff. And then, you know, they got to get their free lunches. So obviously there's stuff that prioritizes a paramedic that just says and comes in and says, hey, we want to do this. I can guarantee you that if you guys have buy-in from your physicians, that you're going to be more successful than anybody else. So I'll just take Grangeville, for example, because I know Grangeville very well. You know, you need to start talking to your docs that you see a lot of their patients. So, you know, if one of the physicians are more of a geriatric specialty up there, get them to buy in first and then move into everybody else. Sometimes as groups get larger, sometimes they have representatives that represent the PCP, and so you might want to get them involved. You want to just tell them that, hey, why we're doing this, we're going to be collecting data and seeing the success rate. And so we may need to ask some stuff of you guys. What the physicians would probably like to see is, you know, does this actually reduce the amount of ER visits for your patients? Is this proven that it's doing better? And, you know, are your patients having a better standard of care? And just like with the hospitals, the insurance companies are starting to push a bundle payment to the physicians. So as long as they meet a certain criteria, they'll get a certain amount of money. And with that, they'll get bonuses for keeping those people out of the ERs and keeping them healthy. And so as the healthcare changes, the payments, they're going to be more and more interested in trying to reduce the amount of people that are going to the ER. You can also use your other stakeholders to help get your clinicians engaged. So, you know, if you have other people that are like, yes, this community paramedic, this community EMT program is going to be awesome, and we really want it to be part of it, like maybe your hospital administrators or maybe some local area council members, get them to talk to the physicians and get them to buy in, because sometimes it just needs a little bit of support or cheerleaders to help drive your program forward. Make sure you develop a message for your physicians. You don't want to just go in there and say, hey, we want to do this, you know, kind of like what I said earlier. You could definitely want to have kind of an idea, a plan on what you're going to tell them. You know, reference some nationwide agencies. Like we said, there's tons and tons of data out there, especially on NAEMT, to kind of drive that sell to your physicians. So you can include the needs assessments that you guys collect throughout the area and say, hey, here's where we identified the needs and this is how we can help. And we've also realized that within your clinic, you know, you got a high diabetic population, so we'd like to help you reduce the amount of issues you have with your diabetics. And then you might also want to educate them on what kind of paperwork they might see with it from you guys. So with Payette, we had a form that we faxed to them whenever we identified an issue, saying, hey, we came out to the residents, we did an assessment, we did not only a falls assessment, but we did an in-home assessment. These are the issues or concerns that we had. This is what we were able to change, and then these are my ask of you. And if they're used to seeing that, then you know, they'll probably be more receptive to it. But if it just showed up on their fax machine, they had no idea what it is, they're probably less prone to really engage with that paperwork. We had some success with some physicians that were like, right on, I love this, this is great. And then other ones that you wouldn't even get a response back after a fax. As you move forward into EMRs, or electronic data exchange programs, HDE, yeah, health data exchange programs, hopefully some of that stuff will be incorporated straight into the chart. So as you guys move forward with your programs, just think about that on the back end, is how can electric data exchange or health data exchange be a benefit to this program and to the physicians. So what would be cool is you go out and you do an assessment, and that chart that you did actually flows right into the physician's office. And I can tell you that they're trying to make that stuff work now. I don't know where we're at with that, but and if you remind me later, I'll tell you about a cool program that we're doing here at Victory that might influence a lot of you guys. Patient-centered medical homes, definitely. If this is the first time you've heard about a patient-centered medical home, it's more of a model that puts a patient as the forefront of the care. And so your patient's like in the middle of this medical home, and everybody else just kind of collaborates together in order to help that patient. And so, you know, being able to reference patient-centered medical home as you're talking with your physicians will make them go, hey, these guys know what they're talking about. You know, these are words that everybody's spitting around right now. And these are important things to kind of be able to know. So make sure that you talk about the sharing of the information again. And that once again goes into that health data exchange that hopefully we can all get on. But if not, just the fact that, hey, we visited, let's say Kim's example, we visited Bob 7 times for falling, you know, in the past month, and we're really concerned about him. They really would, you know, that's what that patient medical home is about, is sharing that information constantly. They focus on social determinants, or treating the issues of the social issues. And so that's super important. We'll talk about that more later, but 99% of the time you guys will be dealing with the social determinants. So, you know, we kind of have our necessities in our life, right? We need food, we need shelter, we need love. And so you're going to find that that's a lot of the stuff that you're going to be focusing on as community paramedics or community EMTs. And you're going to be doing less of your medical stuff that you're used to. And the patient-centered medical home focuses on that too, where, you know, we want good behavioral health, and we want good physical health. We want good financial health. All right. So this is kind of an example of this patient-centered medical home, and we'll zoom into this. I know it's probably a little hard to see on your guys' deal, but the first one is just access to care, right? So what would be great is if you were able to call your physician and say, hey, I need to come in and see you today, and you were able to come in. I mean, that's their focus. We're not quite there yet, and I don't know if we ever will be, but it's definitely something they're focusing on. After hours access, you know, instead of just utilizing the ED as our after-hour care, having maybe some better options for people in the future. And so I know one thing that a lot of health health insurance companies are doing are now apps where you can log in and talk to a physician 24/7, right? So if you have those minor things like nausea, vomiting, diarrhea, UTI symptoms, earaches, cough, you can call on your iPad, get to a doctor within 15 minutes, and hopefully have a script sent to the local Walgreens. Or in some of your rural areas, unfortunately, you probably have to wait the next day in order to get your prescriptions filled, but at least they'll be there in the morning. And then also the imaging and lab services, just making them more available. Next part is care management. You know, promoting wellness, teaching people wellness, how to eat better, how to eat for their medical condition, right? Because certain people have certain diets. Talk more about disease prevention and how to manage your chronic diseases when you do have them. Care coordination, getting everybody together, making them talk, making sure that, you know, everybody's in the right spot when they need to be. I know that one of our physicians down here in Boise, a great friend of mine, is actually looking at creating what they call an externalist. So we've all heard of internalist, right? Inside the hospital. Now they're talking about an externalist, which is where the patient goes when they're discharged from the hospital, but they're not stable enough to go back to their primary care doctor. So the externalist kind of handles their chronic care until they're stable enough then to pass off to their primary care doctor. And so there's more of this making sure that the patients are at the right specialty level at the level that they need. Care team, they're always talking about kind of a physician-led team, making sure that the patient participates in their own health and getting the family involved too to make sure that they know what's going on with the patient and just creating better communication between everybody within that team. Fiscal responsibility, we talked about this earlier, trying to provide a better care for less cost. Don't really need to go into that a whole lot. Health data exchange, once again, we've talked about that. And then quality and safety. We always want to make sure what we're doing is safe for our patients, make sure that we're doing good QA, QI on what we're doing. And just also looking at medication management, making sure that our patients aren't taking the wrong meds or the wrong dosaging, trying to reduce that medication errors. So that's kind of how we focus on patient-centered medical home. So, you know, you can kind of see where community paramedics can definitely be part of that patient-centered medical home. You know, could we be the same day appointments? So if somebody calls in a physician and says, I need to see you, could we be the ones that go out there and see them for the physicians? Are we the ones that are going to be the ones that are talking to them about their chronic management of their diseases? We already talking about prevention of injuries, right? And wellness promotion. And then we were talking about doing health data exchange. So there's a lot of places where we can kind of fit ourselves into that home, and we just need to sell that to the physicians and say, hey, this is where we can help. All right, so patient engagement. This is probably the most frustrating thing, is getting your patients to want to get involved, right? I think sometimes patients just think that you know, nothing's going to happen to them. Or, you know, I think sometimes they don't know why they need to change the way they're doing things now, right? And so I think getting them engaged is going to be one of the toughest things that you guys will do. We talk about effective communication. One of the things that we did for community paramedicine is kind of train on how to kind of talk to our patients and make them think that the idea for you to be there is their idea. Or if they want to focus on a few things, that it was their idea to focus on those few things. And they seemed to be more engaged if you did that. So let's say you sat down with a patient, you're like, hey, we've been referred to you, we want to follow up with you. These are the issues we found, and you can give out 10 issues, right? And then say, pick the top 3 that you want to focus on. And then they'll pick the top 3, and they'll actually be more engaged in doing that than you saying, hey, you're a COPDer and I want you to quit smoking. Well, if your patient doesn't want to quit smoking, you're not going to get them to quit smoking. So if the COPDer was like, yeah, I'd really like to reduce the amount of smoking I do, then maybe that's how you focus on it, right? You help them reduce it. Or if they're a COPD and they're like, you know, I don't want to quit smoking, but I want to have a better, I want to exercise more, then that can be your focus. Because hopefully soon the rest of that will fall into place. But you'll have better engagement from your patients if they think that the idea was theirs. And then just talking about the referral process, and I'll open this up for some discussion, but you know, we have multiple different sources for our referrals. And so number one is going to be internal referrals, right? You guys show up on a scene of a call. We kind of call it the boots on the ground. You guys realize that, hey, there's an issue with this patient. We probably should follow up with them. And you can create an internal process within your agency for your providers to be able to send that referral to you. I know what we did is we had an app at Payet that they can actually go into, put the call number, what their concern was, and then send it to it, and they would email it to the community paramedicine and the nice community paramedic. The nice part of that, there was no HIPAA violation because it was just a call number, right? So somebody would have to know what that call number meant. But it was quick and easy to get that referral over, and it was really easy for our providers to be able to send that referral because nobody wants to do a lot of paperwork, especially not in 3 in the morning when they're helping grandma. Some other places that you guys might get some referrals is like from the emergency room, people overutilizing the ER. I kind of ran the data. We see 9% of the population that actually go into the ER. So you can imagine there's 91% of the people we don't even actually see that could be utilizing the ER. And so ER is going to probably see a lot of people that you don't see. And I think Kim could probably say this too, because I know she works in the ER quite a bit, is that, you know, there's some frequent flyers in the ER, there's frequent flyers in the ambulance, and sometimes they don't match with each other. Primary care doctors, obviously, the great resource for you guys if you can get tagged in with a PCP and be able to get referrals from them. Discharge planners, that's their whole job, is to set people up with you know, services out after they leave the hospital, and the same thing with the transition teams. So with that, I'm going to leave it open to you guys, and I want you to come up with some ideas of different people that might be able to refer patients to your community paramedicine program.
What about like physical therapy places?
Yeah, definitely like a physical therapist that says, hey, we're really concerned about this patient. Maybe they come in every time they're getting worse and they're not really following through with what they're doing, or B, they identified some other issue. Yeah.
How about pastors or chaplains?
Yeah, that'd be a good source. A lot of people rely heavily on their church. I know the LDS community, you know, they kind of go internal first and then move out. So that's a good choice. In your rural areas, a lot of times, who are the people that show up before the ambulance shows up?
QRU.
QRU, yes, which can include
Neighbors.
who? Neighbors, yeah. Police department. Yeah, so good. So if you have a fire department that responds to, that might be a good option, getting your fire departments involved. I know a lot of people don't have that. Is there anybody else that you can think of that maybe probably someone you wouldn't normally think would be a referral source? All right, so here's some fun ones to think about. Your Meals on Wheels people. They usually see the patients every single day when they deliver their food. Newspaper people. And why is that? They start seeing the newspaper stack up outside their door, wondering why. The other good one is your electric companies. They'll go to some of the older homes and go to turn off the power and realize it's an elderly person and they legally can't, or they won't shut off the power. And then they're kind of stuck, right? How do I help this guy keep his power running? Or your gas companies too. So those are some abnormal ones that can definitely, you know, you might want to connect with and just say, hey, we have this program that you're able to refer to. And you'd be surprised how many people will actually refer to you out of those programs. With those fun ones, anybody else think of some other abnormal referral sources? All right, let's keep moving. Some things that are going to help you guys out, and the things that we identified pretty quickly is, number one, it was very awkward showing up at somebody's house and saying, hey, I'm with Pitt County Paramedics and your doctor referred me to you. And they go, well, my doctor didn't say anything about it, right? They're like, well, who are you and why are you here? The other thing that they always wonder about is how much does it cost, right? So we were working on a grant. So when we did talk to them, we told them, hey, there's no cost to you. There won't be a bill. This is just a free service. We're lucky to have this grant, and we definitely want to help you out. The other thing that we identified pretty quickly is over the phone conversations usually end up in a no for the referral. So you call them and you say, hey, I'm Travis with Pitt County Paramedics and got this awesome program for you, or, we can come in and help you. And they go, yeah, no, I'm not interested. 90% of the time when we showed up at their front door and said, hey, this is the program I'm doing, and we're dressed in uniform, we were allowed to gain access to their house. And so a lot of times what we do is drive to the residents and just say, hey, I'd like to schedule a time to come back and spend some time with you and go through your medications and go through all these concerns that the doctor has. And with that, more people were prone to say yes. You still get those 10% that are like, I don't know what you're talking about, get off my front porch. I prefer to have a release sign prior to the referral. So a lot of times your ERs can receive, like if they're going to send a referral to you, they can say, hey, here's a program we're talking about. Can you sign the release that says, yes, you guys can come in and see us? Just a legality thing, but it just makes me feel a little bit more comfortable having that agreed referral. Sometimes it'd be good just to have your referral sources say, hey, a community paramedic will call you within 24 or 48 hours. It would be even better if you were able to say, and his name is Steve, or his name is Adam, or her name is Sadie. So being able to say stuff like that, I think brings that a good, gosh, my loss for words today. I'm so sorry, guys. Kind of puts their mind at ease about the phone call and who's approaching them. Always recommend calling the patient within 24 to 48 hours after you get the referral. The reason being is the longer you wait, the less chance that they are to follow through with the referral. They'll say, well, I've been out of the hospital for a week and I'm fine, so why do I need you now, right? So get on those really, really quick, and then just make sure your appointment's within 48 to 72 hours. Importance of that is obviously, especially with like CHFers and COPDers, you wait much longer than that and they're going to continue to deteriorate to the point where you're probably just going to go back out on them on an ambulance call.
I have a question, Travis.
Yeah, go ahead.
So like people at the hospital, like your discharge planner, do they ever make suggestions to the patients when they leave about having a chem?
So yeah, Kim, we actually had, they're a specialty team within the hospital for discharge planning, but at Luke's, they have what's called a CHF clinic. And so what they would do is tell them that, hey, we're going to send you off to the community paramedic because you're outside of the realm of our area. So the CHF clinic saw people within the Boise and Nampa area, but they wouldn't go any farther than that. And so anybody that was in Payette or Washington County, they would send that referral, and it was the discharge planner or the clinician there that would say, this is who's going to follow up with you. Your discharge planners would be an excellent source to be able to, get that initial contact and get the paperwork signed for you.
So have you ever had like, so like with me already working at the hospital, would a discharge planner ever make the suggestion to a patient who's getting ready to leave, hey, if you would like, Kim's working today, do you want to come in and meet her? And then you guys can talk about things that you're going to talk about, and then she'll follow up with you at home.
Yeah, and I think that would be even more extraordinary to be able to do that. I mean, you're at a great opportunity to be able to do that. If you guys had, at some point, if this transitioned to the point where you had paid EMTs that are on staff, and they were to do that, I would, yeah, literally what you said, have them come in and introduce themselves as a patient, talk to them about the program, talk to them about a day that you're going to come by and see them. And I think having that initial talk with them right away is going to make it even more successful. You'll probably have less no's. Kick them while they're down, right, Kim?
Yeah.
So if there is a payment method, because at some point the idea is that there's some sort of payment for this process, right? Like right now we're unfortunately at that point where it's kind of grant funded, but if you guys start out with an idea of what it's going to cost, and if you're able to charge insurance, then just make sure that if there is any responsibility to the patient, that they understand, right off the bat, how much that's going to be. So if it's like a $20 copay, just say, hey, we plan on visiting it 10 times and there's only a $20 copay. And that's going to be more successful in the end, because there's definitely don't want people to be like, now you sent me a bill and I didn't really feel like I needed you. Ensure the patient that you will be sending some stuff out to external stakeholders to, and that you'll be exchanging information between practitioners. I would almost put that in your legal documents when you have them sign the form that says, yes, I consent to, the community paramedic program, just so you don't get in trouble for anything like that. Hold on real quick, guys, sorry. Sorry about that, guys. So that way, if you're sending referrals over to Meals on Wheels or something like that, you guys aren't getting yourselves in trouble for HIPAA, right? So just make sure that you get that signature signed. All right, just like anything, you got to sell yourselves. And so if anything, word of mouth is the best success. It's also the worst thing too, right? You screw up, everybody's going to put it on Facebook and 50 people know. So make sure you utilize your team, your other EMTs to help promote your program. Advertise your success like crazy. If you guys did something good, see if you can get your patient to agree to put it on the news, put it in the newspaper, tell them about the program, make it sound like it's the best thing since peanut butter and jelly sandwiches. Media is your guys' friends, but it also can be your enemies. Like I said, Facebook is probably the worst thing in the world. You make somebody mad, they put it on Facebook and everybody knows. But also on the flip side, if you can get a video of what you guys did for somebody and how it saved their lives and put it on Facebook, that's going to touch hundreds of people, if not thousands, and definitely promote your program. So don't be afraid to use media to your advantage. Make sure you understand your community when you go in and talk to your stakeholders. When selling your program, make sure you know the demographics of your area. Make sure you know about those needs assessments, because they may refer back to that for you. And then also don't be afraid to tell your stakeholders or the people that you're selling to what your barriers are. Don't be afraid to say, hey, one of the biggest problems we have is getting the health data exchange to work with our hospitals, because there may be somebody that's like, yeah, guess what? I have a bunch of money to throw at that because we have a bunch of grant money. That came to us multiple times. When we sat there and told people our problems, people are like, let me see what I can do to help you guys out. And that was huge. Even if it wasn't money related, just something that we had a barrier for, a lot of people have the fixes. So utilize that to your advantage, because there's a lot of people out there with a lot of grant money that love to throw it out at programs just to receive data. So when you talk to your stakeholders, tell them your issues, your obstacles. All right, everybody love the PowerPoint so far? It's the coolest thing. All right, data collection, more fun stuff. You guys have most of you guys use ImageTrend. I think we talked about this before. I don't know if there was anybody else that used a different EMR, but ImageTrend is a great program that you can actually edit to be able to collect the information that you guys want, okay? So use your charting software to be able to collect your data. Try not to do it by pen and paper. You're gonna regret it if you try to. Don't try to do it through an Excel sheet unless you're a master Excel maker. So you put a little bit of work in the beginning on your charting program, it's going to save your butts in the end. And I'll kind of show you as we talk about image trend later in the modules, some of the stuff that you're able to do and then track later. Once again, people are going to ask you for the data when you're talking to hospitals, when you're talking to people with money, they want to see that it works. And so, you know, you want to make sure that you are able to collect that and produce it for them. So if they say, hey, I know you've been running your program for 3 months now, how many falls assessments have you done? And after you did those falls assessments, how much more were you out on that residence after you did that? If you're able to say, hey, not a problem, let me get in my charting system and produce your report within, you know, a day or two and spit that back out at them, they're going to be absolutely amazed by what you guys are doing. And then to be able to say, hey, look, we did 13 falls assessments. They're all frequent flyers of our agency, and we only went on 1 or 2 afterwards for repeat falls. They're going to be like, wow, that program works, right? That's got a 90% success rate. There are going to be some different standards in your EMS responses. So if you currently look at image trend or your charting system now, it's kind of designed for, you know, the 911 response. And so you definitely have to kind of skew your charting program to meet your needs and what you want to collect. And so we were able to still use, we were still on the old image trend when we started our program, Idaho Perks, but we were able to kind of skew those reports so that we could pull the data just from those. And so we put a special identifier on them so that we could separate them from the EMS calls. Definitely want to track patient outcomes. That's important. People are going to ask you how well they did after your program saw them. You definitely want to try to prove that you had an improvement in health. And if you didn't, then maybe we need to do an adjustment to your program. They highly recommend that you guys get surveys. Remember, we talked about the triple aim. One of the things was focusing on patient satisfaction. And so you're going to probably want to get a survey started. You could create probably a survey through your charting software, or you could use programs like SurveyMonkey. They make great surveys. And just tell your patients, be as honest as possible. Tell us how you felt before you saw a KIMS provider. Tell us how you felt afterwards. Tell us how you felt your health was before. Tell us how you feel like your health is now. And they really aren't that complicated of questions, but 90% of the time your patients will say, hey, you know, I felt like my health was really, really bad. KIMS provider came in for about a month, and now I feel more confident in my management of my chronic health care. And then you can also focus on a survey too with your providers if you want. If they notice that, hey, the KIMS program is doing great things, I'm seeing less of my patients, you know, my repeat patients are coming in less, you could create a survey just for them too that's a little bit different than your patient survey. That's all going to be good data that you're going to want to produce when it comes down to talking to insurance companies about, hey, we want to be able to charge for this. I don't remember what this link goes to, so hopefully it still works. This is a patient experience survey. There we go. So this was one, oh, I remember now. This is one our one of our community EMS workers created. Basically pretty simple. Who is your KIMS provider? Please rate your overall health before your visit. Please really rate your level of confidence. And then how much did your health impact your daily activities before? So let's see, all these are before. And then you have your after questions. How would you rate your health after? How would you feel about, looks like you misspelled something there, confidence managing your own healthcare? And then, you know, how did your health negatively impact your life afterwards? And so this is a really quick, easy survey. It takes somebody maybe 5 minutes to complete, but it gives you a lot of data, right? Lets you know that, hey, the patient felt crappy before, but now feels good. There are some core measures that the NAEMT recommend that we collect. There's a long data of stuff that they would like to see everybody collect. It would be impossible unless you're a huge system to be able to collect all those. But there's 18 core measures, there's some big measures, and then there's 4 other measures for the CMMI and the mobile integrated healthcare. These are those measurements, and we can zoom into a little bit. I'm not going to go a lot into detail. This is a very thorough, well put together list of measurements, but it's something that you can utilize to kind of guide what measurements you guys want to give. And so they have them all set up in different colors, so it makes it easy to read. And here, like one of the major data outcomes that they want is, you know, did we increase the number and percentage of patients utilizing patient care or primary care physicians? So the way that we recorded that with PayEd is we would say, we would have a question in our charting is, does the patient have a primary care physician when we saw them the first time? And then in the end, did they end up meeting with the primary care physician afterwards? And that was some piece of data that we could collect very easily, right? Because you just ask the patient, do you have a PCP now? And if they say no, then you set them up with one. If they say yes, then they already had one. Question 2 is medication inventory. You know, was there an increase in the number and percentage of medication inventories conducted with issues identified to communicate to the PCP? So one of the data that we would create is, did we create a medication inventory on this patient? And then the next question would be, did we identify any meta errors? And then if so, did we contact a primary care physician? So those are easy questions that you can answer within your charting software to be able to collect the data on that question. So if you want to go through the nice little, I think it's 12 pages of measurements, you're more than welcome to, and just kind of see, here's some more. You know, did we reduce expenditures for the ED? That's going to be a hard one, right? Did we really reduce the cost of the ED visits? And that would be a hard one to follow. But that's something that they would highly recommend if you had a big program and you had the resources to try to track and follow. All right. When we made this, Idaho had a list of requested data that they wanted from Kevin's programs. I would recircle back with the state and see if they still have these requested data. This a lot of had to do with the SHIP program and what money that they were giving us. But they wanted us to record the quality and experience measure, the utilization, how much did we get utilized? How much did it cost for our community paramedic or EMS programs? And then, you know, kind of the safety and quality behind it. Are we doing QA, QIs on all of our stuff? They created an Excel sheet that's still out there for you guys to get. I think it's on the state website. This is the medication inventory sheet that they had produced that you can keep track of your data. This was the kind of the question about the primary care physicians that we were able to collect. And then they kind of wanted to follow, did the patient have insurance, and if so, what kind? And so this was the data that the state wanted us to report every quarter. And it was good to be able to collect that because then I was able to pull that information out and actually created a PowerPoint for our stakeholders to say, hey, this is the number of medical inventories we did. This is the number of mistakes we found. This is the number of people we connected to primary care physicians. And we used it as a selling point. So even though the state was making us collect this, it actually ended up being beneficial to our program. All right. Stop, collaborate, and listen. All right, team effort. We got to work together as a team in order to make our community paramedic programs work. And so the first thing is get your hospitals, your local EMS agencies, your clinics, your mental health professionals. I know we've kind of mentioned all these before. We kind of mentioned some of the people out there that you guys saw, like the YMCA, the senior health, or the senior centers, all that stuff. Hold on again, sorry guys. It's very busy over here today. Sorry, guys. All right. So we've kind of already talked about all that. I'm going to skip over that. Case study. So here we go. This will be fun. 68-year-old male, congestive heart failure, discharged from the hospital 1 week ago. Patient has a history of hypertension, diabetes, COPD, and CHF. He's been readmitted twice for CHF in the past month, several times in the last year. His last admission was for dyspnea on exertion. He had 2+ pedal edema. He had significant volume overload on the chest x-ray. His ejection fraction was 27%. Does anybody know what the normal ejection fraction is?
I believe it is 55 to 65%.
Perfect. So he's clocking about a little under half of what he should be, right? Good. And he was referred to the CAMS program for the reavoidance program, which just means we're trying to reavoid him from getting readmitted. So, and I think I've kind of touched base on this guy actually last time we talked, but we'll continue to talk about it. So our first visit, 1 week after we enrolled, he had mild increase in difficulty breathing. He still had the 2+ pedal edema. His weight was about 200 pounds. His vitals, you guys can see there, 150/90, heart rate at 96, respirations at 20, and O2 sat to 94% on room air. When he actually sat down on a chair, was able to catch his breath. That was not while he was moving. So, CAMS management, we told him first off, if you have 4 pound or 3 or more pound weight gain in 1 day, you call us ASAP. Within that, the first week, he had a 4-pound weight gain. So he called us. We called his on-call physician and said, hey, can we increase his Lasix? He was on 40 of Lasix. They increased it another 40 for a total of 80. They placed orders to the lab the next day at a local lab that he could actually drive to and get his labs done. And then they scheduled a follow-up 72 hours after the initial visit. The next time we went to saw him, I think it was a few days later, he was doing better. His weight had gone back down the 4 pounds, so he was 4 pounds lighter now. And we said, hey, we think we prevented this patient from being readmitted into the hospital. The estimated cost of readmission would have been $10,000. And luckily, the hospital didn't get any readmission penalty just for this. So as you guys can see, just in that little time and seeing him within 2 or 3 weeks, we save about $10,000 worth of potential readmission cost to the hospital, which is huge, right? So this would be a great case to go to your hospital administrators and say, hey, we know that you guys get fined. We also know that you don't get paid if somebody gets readmitted within 30 days. Look at this prime example of what we did. And this is how we can help save money, okay? Just showing some numbers here. You know, if you were able to prevent 140 people from going into the hospital and you were able to reduce, you know, at least half of those you would assume that over half of those would have been readmitted. You would have saved $1.6 million. So just kind of some fun numbers that are out there that just kind of help sell your program. Of course, your guys' are probably going to be a little less numbers. You're probably not going to see 140 people in a year, but you might. But if you go to the hospital and say, hey, we can prevent you $1.6 million, they probably listen, right? Save you, yeah. Anybody know what a SWOT analysis is? No? I didn't know until I took my community paramedic program. Then I realized as I started becoming an administrator and being more involved in business and money, SWOT analysis are pretty important to follow up. So basically what a SWOT analysis is, you'll probably see it usually in 4 quadrants, right? And it's strengths, weaknesses, opportunities, and threats. And for any time that you create a business or you create an opportunity, you probably should be doing this for yourself, doing a self-evaluation. So what is your strengths as a community paramedicine, right? And so what advantages do your organizations have? And so when you go to present to your providers, you'll actually throw up a SWOT up on the PowerPoint and say, you know, this is our SWOT analysis, and they'll know what that is. And you say, our strengths are, 1, we have instant access to the homes, right? Nobody else has that. Number 2, the community trusts us. We're able to do things that other people aren't able to do, like, you know, get some of these services to them that we have a great access to all these different services. You could talk about the low cost. You know, we're cheaper than sending an EMT out there is cheaper than sending a nurse out to the home, right? And then you may ask your stakeholders, what else do you see as a strength that we bring to your team? You know, how do you view our EMS program, and how do we help you? next is weaknesses. You always want to identify your weaknesses and try to figure out how to improve them. So some of your weaknesses that you can bring up is, you know, trying to think what would be a good weakness for us. Probably the lack of communication with the hospital is probably a weakness that a lot of us EMS agencies have, right? We don't have that connectivity with the hospital that we should. What are some things that you should avoid? Well, we should probably avoid going into the home and installing grab bars that we paid ourselves, because it's just going to make us lose money for our program, right? And then ask your stakeholders, you know, where are we lacking? Where are we not doing good at? What can we do better? Next one is opportunities. Opportunities is going to be important because you're going to kind of identify where you're going to go later in your program. So let's say right now you're just focused on COPD patients, but there's opportunities to follow up on mental health, or there's opportunities in CHF management, or there's opportunities in falls assessments. So identify those and then start getting your program ready to tackle those or identify or to deal with them. Is there changes in your technology that could be an opportunity for you? I can tell you for sure that there's some great stuff with Image Trend that is slowly improving. And I shouldn't say slowly, they're moving pretty fast, but there's a lot of things within your charting program that you guys probably didn't even know existed, or that that you could utilize to make your program more successful. And then threats. What threats do you face? I think our biggest threat is probably financial threat, right? Nobody to support it. Some other obstacles you may face is home health or hospice may be resistant to you guys coming in, maybe fighting you a little bit. And I think that's the majority of what we need out of that. All right. Last part is development. I'm going to try to get the link on this so that way we can watch it individually. So give me just a second here, guys. And I will put it up on the chat box. And if you guys will watch this, this is just a video about Starbucks and how they did their SWOT analysis, so you can kind of understand it a little bit more. All right, that YouTube video is there for you guys. So I'll give you about 5 minutes and you can watch. Everybody able to watch the video? Cool. Hopefully that cleared up my confusion of the SWOT analysis pretty well. But with our CHEMS program, we definitely did a SWOT analysis for each one of our presentations to our stakeholders. Here at Victory, every quarter we meet with our support center and we talk about our SWOT analysis every quarter, how we can improve, where our threats are. So obviously like a threat to our ambulance service would be other private ambulance services, right? Our opportunities would be like, where do we want to move forward to? Other hospitals, other areas. And then our strengths would be more like an all-in-one transport company. And so you can kind of take that SWOT analysis and move it towards your CHEMS program and be able to show people, you know, where you guys are at, and your business people, your stakeholders will respect the fact that you did a SWOT analysis and they'll know all about it. So with that, we are done with module 3. I ran through it really quick, but I think it's because you guys are so loud and talk all the time that it was easy. As I said, I am going to try to run home real quick. So we're going to take about a half-hour break. So with that, we will meet back here at, it would be 7 o'clock your guys' time. And so that gives you enough opportunity to go get some food or whatever you guys need. If I'm a few minutes late, don't leave. Don't leave me. I am coming back. I just got to make it home first. So, all right. Anybody have any questions before we break?
No, we're good here.
All right, cool. I'm actually going to close the room. You guys can still log back in, but I'm going to close the room because when I get to the other computer, it's going to record on that computer. Lastly, don't let me forget before we leave tonight to give you access to last week's Zoom in case you guys need it to review. So I'll give you access to that when we get back. So thank you guys.